Okay, we're doing now IBD, ulcerative colitis, Crohn's, diverticulitis. That all falls under the category of inflammatory bowel disease. So, ulcerative colitis, Crohn's disease, and diverticular disease. These are three large bowel problems, and they happen in certain areas of the large colon. Ulcerative colitis is colon and rectum. Crohn's is most commonly in the colon. It could be anywhere in the colon. Diverticular disease is most likely down into the sigmoid colon area. So let's talk about ulcerative colitis first. Ulcerative colitis exacerbates and remits. It comes and goes. Patients can have an exacerbation and they may not have one for months or years, and then it can come back. So it starts in the rectum area and progresses up the colon. The number one sign and symptom of ulcerative colitis is you have bloody diarrhea. The ulcerations happen on the epithelium layer inside, and it sloughs off that layer. Consequently, you have lots of bloody diarrhea. It can be acute and come on and then stop, or it can be a chronic disorder. These patients do have an increase of colon cancer, so that's something to watch for if they've had it for years. Signs and symptoms. Number one is bloody diarrhea. Abdominal pain, very colicky feeling. They're going to categorize this disease based on bloody stools when it is active in the acute phase. So mild, 1 to 2 stools a day, moderate 4 to 5, severe 10 to 20. So if you're losing cells, it's causing you to bleed, then you will also have anemia. You're at a high risk of dehydration. Also, because of the ulcers, you may run a fever. You're not going to feel like eating, weight loss. So these are basically the problems. You could have absorption issues depending where it's taking place, how far up, absorption of fluid, water back into the system. So diagnostic studies, CBC, WC, serum protein. You need protein to heal. If you're not eating the right foods and have enough serum, you're going to have a hard time healing. So CBC, you're losing blood. WBCs increase because of the ulcers. Best diagnosis is a sigmoidoscopy or a colonoscopy. Best form of diagnosis. Just go in and look at it, see what's going on. Treatment. The best treatment is to rest the bowel. If you're having bloody stools, then you need to rest the bowel. So you may be thinking, well, how am I going to rest the bowel if I have to eat? I'm always going to produce fecal matter. Well, you have to have very low residual, low fiber diet. So surgery, basically 15 to 20%, they will give them an ileostomy. If nothing else is working, you need to reduce the stress. Medications, there are medications. They do not want to give steroids. Corticosteroids are have lots of problems. You have to take them a long period of time. So let's do anything and everything before we do steroids. So for example, Lamodal antidiarrheal would be a good one. Another one is a sulfidine. It is a great one that helps some people. They may give antibiotics to help heal if a patient has high WBCs. So nutrition, the patient needs to have a high calorie diet, high protein, but you need to avoid high residue foods, so low fiber, low residue. So patients could buy elemental diets. It comes in a can. These are low residue, lactose free, they're high in calories. These are diets, they can buy them, it comes in a can, or they can make their own, basically. So you should be able to get all your calories and have everything absorbed in the small intestine before things get to the large intestine. That would be a perfect diet. That's how you rest the bowel. So for example, white rice, high carb, but there's no residue. So other issues. Ulcerative colitis can attack and affect other joints and areas of the body. So it's not just one area. The other issue the patient has when they're in an acute phase is perianal breakdown. If you're having 10 to 20 bloody stools a day or more, then you're going to have skin breakdown. High stress, when this is aggravated, patients are very stressed out, coping. Maybe Ativan or Valium would be something that would help them. These patients probably have history or they will develop depression. If they have an exacerbation, quite often, you can't leave the house, you can't go shopping, you can't go eat out with friends, you can't do stuff because you don't want to be away from the bathroom if you're having lots of bloody diarrhea. Crohn's disease. Crohn's can happen any part of the GI. It's usually in the ileum, jejunum, and colon. It can happen anywhere. So what happens is all layers of the bowel develop this fibrous cobblestone appearance. It's very tough, thickens. It can cause a fistula. It can eat through the colon or the bowel. And if you have a lot on the inside, it can kind of grow together, so you could have a large bowel or a small bowel obstruction. Signs and symptoms are it all depends where you have where the Crohn's is, where the cobblestone happens to be. So signs and symptoms, you can have diarrhea, abdominal pain, weight loss, fever. If there's a blockage, you're going to have symptoms for a blockage. This one also exacerbates and remits. Fistulas are common between the bowel and where? Well, a common one would be anal fistula, but you could have a fistula from anywhere in the bowel into the peritoneal space cavity. So how do we diagnose that? Well, pretty much the same thing. Colonoscopy, sigmoidoscopy, look at it, let's take a biopsy. What kind of labs would you look at and why? Which ones are going to be abnormal? So treatment, same kind of thing as ulcerative colitis, basically. Corticosteroids, basically, if they're on steroids, they're going to have complications of steroid use. What are those? Surgery does not cure this, although you may have an exacerbation where you have a blockage. You can go in and take out the portion, then you anastomose, and then it can show up someplace else. So it's not going to cure it, but it may be something the patient has to have. There's a new synthetic glucocorticoid out there. It's called Endocort. Patients take this every day for about 8 weeks. It's better than taking prednisone or one of the corticosteroids. This is a glucocorticoid synthetic. It's a bit better. Patients, because of infection and what's going on, they may need antibiotics. So Flagyl, Cipro, because of the TNF agents, so Remicade, Humira, these are lifesavers. Patients' their lives have been turned around because of these medications. Although Remicade and Humira basically suppresses your immune system. So these people that take this are also at a high risk of contracting other diseases, other colds, infections. Patients that receive infusions for this, they have to have labs drawn before they get the infusion. If labs don't meet a certain criteria, they will not receive their infusion. Also, they have to be tested for TB. If you go on Remicade and you have latent TB, it will probably cause it to become active. So Crohn's patient need to be on a low fiber diet as well, same as ulcerative colitis. So why would this be helpful? Well, if you have a possibility of blockage because of these cobblestone fibrous masses in your colon, then you don't want a large mass fiber, high residue food going through because it could cause a blockage. So they should be on low residue, low fiber, same kind of thing. Surgery is an option, but it's not going to cure it because it can show up any other place. Coping mechanism. These patients have depression issues. Why? Because their whole life can be altered forever with exacerbations of these problems. So, complications from Crohn's, small bowel obstruction, also long-term drug therapy to get them through it. So here's a slide that just basically shows a differential diagnosis between Crohn's and ulcerative. Notice ulcerative colitis is more common in women. It's a younger population. Crohn's is equal with men and women. The other thing is there is no cure for Crohn's. You could cure ulcerative colitis if you take out the whole colon, but a lot of people do not want to deal with a colonoscopy and things like that. So diverticulosis or diverticulitis. Now, patients can have diverticulosis and not know it and never have diverticulitis. Diverticulitis is when the outpouching in the mucosa become infected, inflamed with fiber, fecal matter, other things. This is usually most common in the sigmoid, so down in the left lower quadrant. When patients have an exacerbation, when it comes on, it is very painful. They need lots of pain meds and antibiotics to cure this. So notice that it doesn't come on with patients less than 35 years of age, because usually what causes this is years and years and years of having a very low fiber diet. So eating food that has no fiber sludging through will cause this. They've noticed at age 85, 2/3 of the population have diverticulosis. Doesn't mean they have diverticulitis, but diverticulosis. So if you have diverticulosis, you don't have any symptoms. Intermittent diarrhea, constipation, if it is currently exacerbated. Patients have that discomfort, left lower quadrant, feels like they've kind of got bloating, it's very painful. It narrows when it becomes inflamed, so difficult to pass stool. That's why they might have intermittent diarrhea and constipation. So same kind of diagnosis. We can do a CAT scan, or let's just do a colonoscopy or a sigmoidoscopy, easier way. Those really are not that big of a deal anymore, and they're so common. Patient needs to have bowel care, clean out the bowel with Go Lightly or one of the other products for that. So treatment, high fiber diet. These patients need high fiber diet. So bulk laxatives, psyllium is a good thing. Antispasmodics, they need to have lots of fluid, extra fluid if they're having high fiber diet. If they're obese, losing weight will help that. They can do a surgery and take out portions of that and put it back together, so a temporary colostomy. Cipro is a good drug, also Flagyl, other ones. Same kind of issues with coping and depression. That's going to come up as well, because life changing, you got to really watch your eating, bathroom habits, things like that.